Hello, and thank you for joining me. My name is Talha Rafeeqi, and I'm a research fellow in pediatric surgery. Today, I'll be talking about pilonidal disease. We know that this disease is a terrible condition that can present as acute abscesses or chronic sinuses in the superior part of the gluteal cleft. Treatment is difficult and not standardized. Less invasive management options include hair removal and hygiene, while surgical options range from incision and drainage for abscesses to more complex excisions with flat base closures for extensive disease. Despite these options, recurrence rates have been reported as high as 30% in the literature. We believe that a standard lack of treatment algorithm may contribute to a high recurrence rate, and we have developed a treatment protocol incorporating minimally invasive pit excision with laser hair removal. We hypothesize that such a protocol can be applied across various hospital settings and would lead to low recurrence rates. Patients are referred to our pilonidal care clinic or find us through our outreach. Depending on how they present, and you can see a diagram of the protocol here, initial management may be with drainage for abscesses or a minimally invasive pit excision, also known as the Gibbs procedure, illustrated here for select patients. The Gibbs procedure is the coring out of individual pits and their associated debris using a trephine without removing healthy tissue. Regardless of initial surgical intervention, all patients in our protocol initiate laser hair removal at or shortly after their first visit. These treatments are administered every 6 to 8 weeks for a total of 6 to 10 treatments with the goal of losing 90 or greater than 90% of hair in the area. In between these treatments, they continue aggressive hair management at home with depilatory creams, shaving, and of course, hygiene. For this study, we included patients that underwent initial pit excision procedures as part of our treatment protocol over our 5-hospital network. Patients that had an incision and drainage prior to presenting to us were also included, but those that had a formal excision procedure prior to presentation at a different hospital or by people outside of our system, or who were non-compliant with our treatment protocol, were all excluded. We collected demographic data as well as length of follow-up and overall treatment history since presentation. We also collected data on recurrence, which we defined as the need for reoperation or the return of symptoms such as pain, drainage, and abscess more than 4 weeks after treatment. We then grouped recurrence data by hospital as well as by surgeon and compared recurrence rates in both groups with ANOVA. After excluding 52 patients for non-adherence to our protocol, we were left with a total of 80 patients. Most were female, and the average age was 18 years old. Patients had been operated on by one of 6 surgeons as part of our protocol in one of 5 hospitals within the network, with a relatively even distribution among the 3 hospitals. We did combine 3 community hospitals into one category for analysis. 3 patients underwent incision and drainage as initial surgery due to the presence of abscess, while the rest underwent the Gibbs procedure. All of them followed up at our academic center for a median of 5 laser treatments over an average follow-up period of 345 days. We witnessed an overall 8% recurrence rate, with recurrence broken down by hospital and surgeon here. We found no significant difference in recurrence based on the operating surgeon or based on the hospital where surgery took place. All of these recurrent patients had undergone the Gibbs procedure rather than IND, and all of them required re-excision. These patients also underwent more laser treatments than the overall group. So 6 patients recurred. We were able to demonstrate successfully that adoption of this standardized protocol, incorporating minimally invasive pit excision with regular follow-up and laser hair removal, results in fewer recurrences when compared to the recurrence rates in the literature. Again, we saw an 8% recurrence compared to 20 to 30% that we've seen in the literature. Our protocol was applied across multiple hospital settings and was adopted by multiple surgeons conducting the same pit excision prior to sending patients for follow-up and for laser hair removal. Hospitals with limited resources can thus provide simple initial treatment with pit excision and then send patients to a larger hospital for more costly hair removal. Such standardization can improve access to care, but it is important to keep in mind that the patient is a critical partner in their care. Patients must adhere to follow-up intervals and to the home hair removal regimens in order to see success. We hope to further study the effects of our standardized protocol with a more extensive prospective study in the future. Thank you again for joining me.